Good morning, everyone, and welcome to the Common Part B Geriatric Medicine Rejections and Denials webinar. I am Mary Mucko. I'm a member of the WPS Provider Outreach and Education team, and I'll be your presenter today. I'm joined by my friend and teammate, Aline Sigler, who will be assisting with some behind-the-scenes help. She'll be monitoring the chat feature for questions as they come in, and we'll cover those time permitting, or if time permits, at the end of my prepared remarks. This webinar today is for those people who are wishing to learn about the most common reasons for WPS claim rejections and denials. And this is specific, just as advertised, for Part B claims that are submitted to WPS by geriatric medicine or specialty 38 providers. Now, CMS requires MACs, MAC is a Medicare Administrative Contractor, to share this education in order to prevent future claim rejections and denials. And just as advertised, the information that I'm presenting in this webinar today is based on actual claims data. Before we get started, I do have a little bit of housekeeping. This presentation is available to download from our live events webpage. The page address is in the chat. You can take time to download the slide deck now, or the presentation materials rather, if you haven't already done so. We are recording this session, and barring any technical issues, we do plan to post this recording on our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also post on our YouTube channel, where it will remain as long as the information remains current or until we otherwise decide we need to remove it. Now, if you have questions, please do place them into the chat. I will answer questions as time permits following my prepared remarks. If I don't get to your question, I will email the response following this webinar, either directly to the learner that posted the question in the chat, or I will prepare a list of questions and answers and share them out with everyone that's participating today. Now, if you have a question that pertains to a specific claim denial or a specific claim, I will be unable to provide you with an answer. I do not have access to any claims information or claims history rather, so I can't see what happened to your claim. For those types of inquiries, you do need to contact customer service, where they can access that claim and provide you with help that you need. Now, we do include a disclaimer in all of our live events, and we do so to let you know that we made every effort to make certain that the information we're providing is current and accurate, but it is subject to change. It is on the CMS website, where you will find the Medicare rules that determine final coverage. CMS does prohibit recording of this webinar for profit-making purposes, and since we don't know how you might use a recording, we ask that you just refrain from doing so altogether. We also remind you that we are recording this webinar, and we will create an encore of the presentation, so you will have access to that recording for future reference. Based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data, I have included the CPT copyright notice in my presentation materials today. Your continued participation in this presentation, this webinar today, does infer that you agree to the terms of this copyright notice. Here is the agenda for today's webinar. It's going to look really familiar to you because this is exactly what I advertised that I plan to cover today. Today, our goal is to share with you those most common rejections and denials for geriatric medicine claims. Now, this is not a deep dive into policy and coverage. We did not advertise it to be that, but it is a look at the most common reasons for specialty 38 rejections and denials based on that actual claims data. I will define rejections and denials. I plan to reveal the most common reasons for rejections and denials based on that data that I pulled and analyzed. And I'm going to discuss ways to fix and avoid these. And I'm also going to provide you with many resources. Now, this is a lot of information. to share in 60 minutes. I'll be moving quickly through these slides, and I may ask you to review some of the information, such as those listed resources following this slide presentation. That information is mostly just a list of those helpful resources. I am going to point some of them out to you. However, if you have questions, I'll tell you later how you can send them to us. Let's get started. In order for me to discuss rejections and denials, I do need to provide a bit of information about the claim process. Based on a law that requires it, most providers and suppliers submit claims electronically to Medicare. When those claims are submitted and when they come in the door, if you will, there's reports that generate, that confirm claim receipt, and sometimes they reports include even more specific information about those data requirements that we have or that Medicare has. Now, one of these reports is the 276-277 report. Our electronic data interchange, or EDI staff, did create a 276-277 companion guide. They prepared this to help submitters understand the claim requirements and also to know and recognize when they need to correct or resubmit claims. We call these pre-pass edits. Claims that move past the pre-pass edits are going to generate a remittance advice. This is also referred to as the RA. Some people call it the notice. A lot of people have different names for the remittance advice, and so you might hear me calling it the RA, the remit, or the notice throughout this presentation today. Now, there are two formats: the electronic remittance advice, which is the ERA, and also the standard paper remittance, or the SPR. Now, with very few exceptions, most providers or suppliers are going to receive the electronic remittance advice. Now, that remittance advice has key information for providers. The information is important to you to recognize how Medicare did or did not process the claim. For adjudicated claims, you can find information about adjustments, denials, sometimes missing items, refunds, and even sometimes the RA will include information about offsets. So a lot of financial information. When you're looking at a remittance advice, you're going to find various reason and remark codes, and these are typically in an alphanumeric format. When claims pay differently than filed, or than billed, I should say, a claim adjustment reason code is going to appear on that remittance advice. Sometimes a remittance advice remark code will also appear, and those remark codes, expand on the details that are described by the reason code. And they do so just to provide more details about the adjustment to the claim. Another type of code on the remittance advice is a group code, and group codes assign financial liability for any unpaid balance on a claim. If you see a CO group code on the remittance advice, that stands for contractual obligation, and what that means is the provider's liable and you cannot bill the patient. A PR on the remittance advice or the notice means that the patient is financially responsible. Now, WPS hears a lot of comments about these codes, these reason and remark codes, sometimes the group codes, but mostly the reason and remark codes. Providers often state when having a conversation with one of our customer service representatives that these codes that print out on the remittance advice are too cryptic, or that they contain outdated acronyms or information. While WPS would really love to help, another contractor, not WPS, does maintain these codes for CMS. You can find a link to the code lists on their website. That company is the Washington Publishing Company. It is on their website where you can find contact information should you wish to suggest a change to any of those reason and remark codes, including those sometimes cryptic code explanations. Next, I want to talk about the differences between a rejection and a denial. I'm going to share with you, based on the data pull and what I analyzed, those most common rejections and denials today, but you do need to understand that there is a very huge difference between a rejection and a denial. And the reason I say this is because a lot of times when we talk about rejections and denials, we use those words interchangeably, and we really shouldn't, because they're very, very different. The actions you need to take for a rejection versus a denial are very different. A rejection is a claim that's unprocessable. That's what CMS calls it. It's unprocessable, it's rejected, it's returned on what we call the front end before the claim is adjudicated. And the reason we reject claims is because something's illogical, invalid, missing, something's incorrect, something just doesn't make sense. Because rejected claims are never adjudicated, there are no appeal rights. What you need to do is fix it and resubmit it. When you receive a remittance advice that has an MA130 and a CO16 code on it, that means the claim was rejected. It was unprocessable. You need to fix it, resubmit it. The patient is not liable. You cannot bill the patient. A denial, on the other hand, represents a claim or claim line that was adjudicated by the MAC. The reason for denials could be a number of things. I've included some of them here on this slide for you. Perhaps there is a law that says we can't pay for this item or service. That's called a statutory requirement. Maybe the claim or claim line is denied due to medical necessity. Frequency parameters, utilization guidelines are a form of medical necessity. And remember, for medical necessity denials, you can consider presenting your patient with that advance beneficiary notice of non-coverage, or the ABN. We have a lot of education about the ABN out on our website and also on our YouTube channel if you're looking for more information or education on the ABN. Eligibility is another reason why we denied claims, and this is quite one that is quite frequent and quite common. When I started all of these sessions on claim rejections and denials, I started at specialty 01. We're now up to 38, specialty 38, which represents geriatric medicine. A lot of the most common reasons for denials is eligibility. MA01 is the code you're going to see on a remittance advice that provides appeal rights. Now, with very few exceptions, most denied services, not all, most, do afford an appeal right. For denied services, just as I mentioned a little bit earlier in my presentation, the patient liability is determined. Sometimes the patient's responsible, sometimes the patient isn't, and that's where that ABN comes into play. All right, now during the next few slides, I'm going to discuss whether you're going to need to fix it or correct it or appeal that claim. After reviewing that remittance advice, you're going to need to choose your next action. For an unprocessable or rejected claim, you need to fix the error and resubmit the claim to Medicare. If the claim or the claim line denied, though, there may be multiple actions to choose from. This slide has a few of them here listed. If the claim or claim line denied, you may be able to simply resubmit the claim. You might use a process called the clerical error reopening, or CER process, to reopen the claim. CMS defines clerical errors as human or mechanical errors on the part of the party or the contractor. So for those clerical errors, those minor errors or omissions, you can consider that CER process. We do have a self-service option for reopening a Part B claim. It is available on the SecureNet Access portal. We call that tool SNAP. That is the secure side of our website. I'll talk about that a little bit more later. Registered users of that SecureNet Access portal have that option. Self-service tools really do offer the most efficiencies. We do have a portal user manual available on our website, and I'm going to show you that here just real quick. I'm getting it ready. I'm going to pull it over onto the screen so you can see it. I just want to show you where that portal user manual is available on our website. You can find it in a number of places. Up near the top of our website homepage, which is what you're viewing now, I'm scrolling down, you can see a link right over here. You can see my cursor moving to that portal user manual. You can also find the portal user manual on every single web page in the big blue box located at the bottom of the page. It's right here, the portal user manual. It appears under educational materials. Why is this so important? It's important because those of you who are users of this tool, and if you've ever talked to someone who uses the tool, it's a very helpful tool. That portal user has both illustrations and step-by-step instructions on how to use all of the features that are available in our Secure Net Access portal, including that clerical error reopening. Using that tool, whether you're using the tool or not, another option or action to choose to fix a denial would be to request an appeal or to receive payment for that denied service, I should say, rather than fix. Oh, my fingers got a little fast there when I moved forward. So we've talked about those potential actions. I do want to expand just a little bit on appeals, and I'm going to do this quickly because we didn't advertise this webinar is about appeals, but it certainly is something you can consider when your claim is denied. With few exceptions. There's just few exceptions to those claims or those denials that are that the appeal right is available for. There are 5 levels of appeal. There's only one level of appeal that's done here at WPS or at the MAC level, and that is the level 1 redetermination. All 5 levels of appeals have time limits for the provider or the supplier to file their request. But there's also time limits that apply to those contractors that are completing those appeals. And they need to make their decision and send that decision letter back to the provider or the supplier. There are time limits there too. There are 2 levels of the appeals that have an amount in controversy, and that is a minimum dollar threshold that applies in order for you to be able to request that level of appeal. That applies to level 3 and level 5. Now you might notice here on this slide, I mentioned the 5 levels, but I do not list them all because I'm going to show you where I find that information. There's a couple of places I look for, that detailed information about the appeals process, including those time frames. Here on this slide, the first bullet is a resource available on our website, which is called How to Appeal a Claim Determination. You may have noticed in my presentation materials that you've received electronically that there are links embedded. So you can very quickly get to this information simply by clicking on the link that I've embedded for you, and it will open that particular resource. Very important because you'll see soon at the end of the presentation that there are a lot of resources included. So just a nice way for you to find things quickly. So here is that resource, How to Appeal a Claim Determination. It has, how to submit your request. You'll see here that this particular information is specific to Indiana and Michigan. That's because when I entered our website, I chose Indiana and Michigan Part B. If you look at this ribbon near the top of the web page, you can move between contracts really easily simply by clicking on them. Previously, I was looking at JA8 MAC Part B. We're now looking at J5. So the addresses that you'll see and mentions throughout this particular resource will be specific to Iowa, Kansas, Missouri, and Nebraska. And of course, we are on the Part B website. It says so that the jurisdictions, all of them apply for this particular resource. But again, you can quickly move through the various contracts we have by clicking on the ribbon near the top of the page of the website. Now I'm going to share with you one of my favorite CMS resources, and that is the second bulleted item. There's a screenshot here or a graphic that shows what I'm talking about next. But I am going to open it up to talk about because I want to show it to you as it appears right from the website itself. This is the CMS fee-for-service appeals process flowchart. And here it comes. It's just taking its time. I'll pull it open again for you to look at as I talk about it. I really like this CMS publication. it shows you the initial determination for the standard process Part A and Part B appeals process. It is the max initial determination. So that's the initial processing of a claim. You have 120 days to file the first level of appeal, which is the MAC redetermination. The MAC has 60 days to make their decision and send you the notification. Then you have 180 days to file the second level of appeal, which is done by the qualified independent contractor. It's called the reconsideration. There's a 60-day time limit for them to make their decision. And you can see this goes on to talk about the third level of appeal, fourth level of appeal, and then the final and fifth level of appeal, which is federal district court. Remember that I mentioned to you those amounts in controversy for levels 3 and levels 5? You can find that information on this appeals flowchart. It is right here. You can see for the third level of appeal, the ALJ hearing, the amount in controversy is greater than or equal to $190. So that has to be the amount, that threshold amount that's in dispute over that claim line or claim that didn't pay. Now, you can combine similar denials and submit them in order to reach that minimum threshold, that amount in controversy. You'll see here that the amount in controversy for federal district court or a level 5 appeal is $1,900. All right, that flowchart is updated annually. Be sure that you're looking at the bottom of that flowchart when it appears to see the amounts, or that the chart reflects the amounts for a particular calendar year. You know, just something to make note of as we get close to the new calendar year each year. All right. All right, now we're going to talk data, folks. As I mentioned, I pulled data for this presentation. I used a tool that we call the data dashboard, or the claims data dashboard. The data dashboard is really an interactive tool, and it was designed by our data analysts in our insight department. That's the name of our data department. They are responsible for mining data, creating these dashboards so that people like Aline and I in provider outreach and education can just with a click of the button look at data so we can analyze it to, at least for us in provider outreach and education, to support the need for education. Why are we educating on what we're educating on? We need the data to show that there's a reason or a need. We also look at data trends. And of course, our insight staff has other tasks and responsibilities too. They work very closely with policy and medical review, as well as customer service and education and outreach. Now, there's different ways to view that data that's available in that dashboard, and we can, in an instant, just simply by clicking enter, view rejections or denials. We can drill down by state and even county. We can look at reasons. We can look at the data by a particular CPT or HCPCS code. We can look at a specialty code if we'd like to, or include all specialties. And of course, as I mentioned, we can look at trending. And I just find it incredible that this tool that our data folks has created for us to use is so simple to use, and just a click of the button allows us to drill down. When we're drilling down, we call those various items that we choose to see data slicers. So when preparing for today's webinar, the data slicers that I used included claims for both Jurisdiction 5 and Jurisdiction 8. That's both of our Medicare Administrative Contractor contracts. Jurisdiction 5 is Iowa, Kansas, Missouri, Nebraska. Jurisdiction 8 is Indiana and Michigan. Just as I advertised, this webinar today is going to reveal Part B common rejections and denials. Specialty 38, geriatric medicine. So I used a data slicer, which really just equates to a drop-down menu when you're using this tool. And I can't show you the tool because it is inside a secure environment. I chose geriatric medicine, specialty 38. And for those of you that might be wondering what a specialty code is, I know I've mentioned specialty 38 a few times already. It is a 2-digit code that we assign to providers when they enroll. Now, most providers self-designate their primary specialty. Some providers can even designate a secondary specialty or a tertiary specialty, but CMS does maintain a list of specialty codes, 2-digit codes, that describe the different specialties within Medicare. So it is only that primary specialty code that is considered during initial claim processing. It is that one that a lot of providers self-designate that is used during that processing. Now, there are some situations where a provider will request an appeal and stipulate that they have a secondary specialty, and then Medicare can make payment for that item or service. So something to be aware of. You can change your specialty code if there's a need to do so, but that would be a process that is helped along by our provider enrollment staff or through the use of the provider enrollment chain and ownership system, which is called PACOS. And that is an altogether different webinar, but in order to change your specialty code, you would have to use PACOS and go through that provider enrollment process. So I pulled claims for submission dates March 1 of 2025 through May 31 of 2025. It says here the data was last refreshed on June 10th. What happens, and what we mean by this, is we pull claims information, or rejections and denials, that is, most often in this tool anyway, in a 3-month chunk of time. Okay, so this is March through May, March, April, and May. And it was refreshed on June 10th. Now on July 10th, our data analysts refreshed this data, and the data now would show April 1 of 2025 through June 30 of 2025. So we add a month and we take a month off. That's that refresh date that I'm talking about. But in order to prepare and get this PowerPoint and these presentation materials to you on time, based on my work instructions, when I pulled data and analyzed it, the dates that I use, submission dates, is March through May. So here, folks, then, just as I promised in that webinar description, I am revealing the most common reasons why specialty 38 claims, geriatric medicine claims, submitted to WPS during that 3-month time frame I just talked about, rejected. We're talking rejections first. You'll see I have reasons listed here, followed by a number, and that number represents the number of claim lines. Patient not enrolled in demo at the time service rendered, 144 rejections in that 3-month time frame. Rendering physician number invalid or missing, 121. Claim must be submitted to the RRB, that's the Railroad Board Contractor, 64. Invalid or missing modifier is another common reason, 39. And this should be billed with appropriate code for these services, 13 rejections, not denials. They're very different. Remember, the way the actions you need to take to fix it are different from that of a denial. I'm going to talk about the demo that applies here to the first bulleted item in just a minute. But for the second one, if you're to fix or resubmit that claim, what are you going to do? You're going to take a look at your claim. You're going to look at the claim form instructions and find, is that rendering physician number reported on that claim invalid? Is it missing altogether? Was there transposition in the number when it was keyed? Those are the kind of things you're going to look at to fix that. For the rejection, that is, the claim should be submitted to the Railroad Retirement Board. What you need to do is, check to make certain your patients have Part B through the Medicare Administrative Contractor, or is it a retired railroad employee? Railroad employees, those that are retired that have Medicare, have claims that need to be submitted to the Railroad Board Contractor. Well, how do you tell if a beneficiary has railroad coverage, Railroad Board coverage? You would need to check the eligibility files for the beneficiary. And another way is a quick look at their Medicare card. The Medicare card for a railroad retiree is different than for other Medicare beneficiaries. Right across the bottom, it will say Railroad Board if it's a railroad retiree. So something to share perhaps with those within your organization that meet and greet your patients. Those people asking, can I see your Medicare card? Do you have a Medicare card? Can I see it? Make a copy of it, so on and so forth. Check what it says on there. Invalid or missing modifier modifier, you would look, the tools you would use there would be to look at, well, look to see, you know, is there a modifier required for that particular item or service? Is it invalid, what was typed on there? Is it one that simply can't be used with that particular procedure code? You can find help on that, or help for modifiers out on our website. I'll show you quickly. If you just simply go to any page of our website, I'm a searcher, folks, not a navigator, so you're going to notice that I am searching a lot to demonstrate things during this presentation today, but you can also, of course, navigate by using our topic center here, and the modifiers are available under the claims topic center. But if you look to the modifiers webpage that we have, I'm going to make this a little bigger for you, you'll see listed on this page are links to several different modifiers. One nice thing about these particular fact sheets for many of them, and I'll see if I can find one that might have what I'm looking for here specific. I'm going to look at modifier 25 fact sheet. Most of the fact sheets are laid out the same. You have a definition, you have appropriate use, you have inappropriate use. In this case, there's some statements that are false. And then we list on many of these fact sheets, not all of them, the appropriate procedure codes. So when you were getting a remittance advice that says invalid or missing modifier, you need to make certain that that modifier code you're reporting is valid for the procedure code you're billing. And what I'm talking about there is this kind of information right here from the fact sheet. Modifier 25 is valid for only these CPT codes, CPT and HCPCS codes. So helpful tools. This should be billed with appropriate code for these services. That means the code chosen and reported on the claim is likely not specific for the services that were billed and the claim was rejected. A few more common rejections. Place of service conflicts with procedure code. So for example, if somebody's billing a major surgery, it's likely not going to be billed in an office. So if a claim comes into Medicare with an office place of service and it's a major surgery, that place of service is going to conflict. 9 rejections. The next one is that the claim should be sent to UMWA. You know, some of you might not be familiar with that acronym, and the reason why I used acronyms on my slides is that is exactly how that reason code prints out when you analyze the data. So when you're looking at your remittance advice, you might find some acronyms there. Sometimes they're out of date, such as the last one here, HCPCS. That's not a valid acronym any longer. It's now a Medicare beneficiary identifier. But back to this common rejection claim should be sent to UMWA. I apologize. UMWA stands for United Mine Workers of America. Their health and retirement funds have a special arrangement with Medicare. I'm going to pause for just a moment, folks. Thanks for your patience and sticking in there with me. I needed to remove a barking dog from hearing distance. Back to UMWA, their health and retirement funds do have a special arrangement with Medicare for coverage of retired miners. The fund is the primary payer for Medicare Part B services, as long as that beneficiary has no other group health plan that is primary. So in this case, that claim came to WPS and was rejected because that particular beneficiary does have the United Mine Workers of America Health and Retirement Funds because they are a retired miner. Again, that would be an eligibility issue. So when confirming eligibility for your patient or interviewing your patient, those are the kind of questions you're going to want to be asking and seeking information on who is the primary payer for that particular beneficiary. Another reason for rejection is one E&M code for services covered per course of care. This would be a computer edit, coding logic, computer logic when more than one E&M code for a service per course of care is being billed. There may be a rejection based on those edits in the system. Patient insured HICN, health insurance claim number, now the Medicare beneficiary identifier, and name do not match. What this means is that the Medicare beneficiary identifier for a particular beneficiary, is going to be on that Medicare card along with their name. You need to make certain that the health insurance claim number and the name match exactly. For example, if the Medicare card has the patient's middle initial on it, your claim needs to have that middle initial on it. So that's what we're talking about here. I thought it would be interesting not just to tell you the reason why your specialty claims are rejecting, but also to share with you the most common services that WPS is rejecting. Now, remember, this is based on that data analyzed for this webinar today. The number one most common rejection, and these go in order, number one, number two, number three, and so on and so forth in the next few slides. This represents the service and the reason we are rejecting these claims for Specialty 38. The number one reason why 99309, which is a subsequent nursing facility care for patients with high complexity health conditions and so on and so forth. The number one reason we're rejecting those claims is because the claim should be submitted to the Railroad Board, not to WPS. Let's look at the second most common rejection reason. Claims should be submitted to United Mine Workers of America. Okay, those are both eligibility issues. And the number three reason why we are rejecting, or not rejecting, yes, it is rejecting. I'm talking rejections. I get myself confused here. Remember, rejections are very different from denials. Is that the patient or insurance HIC number and name do not match. The next code is G0523, and this is a relatively new code. It's used for the management of a new patient with dementia, moderate to high complexity, and this code is part of the CMS model for care management in what they call the guide model. This is a code specifically used in the comprehensive primary care model. This is part of the CMS Innovation Center that was established by Congress in 2010. So this, folks, is a demonstration. And remember, I'm going to move back a couple of slides here because I told you that I would talk more about this later. I'm talking about the number one reason geriatric medicine claims were rejected by WPS. The patient wasn't enrolled in that demonstration at the time the service was rendered. As part of this demonstration project, this guide model, part of this demonstration requires that providers enroll or the patients enroll and such. And I do have a resource for you listed within your presentation materials that tells you what you need to do if you're billing for these services. So I do have that resource so that you can avoid this second most common reason for rejections of geriatric medicine claim. Second reason why this code is rejecting is that this should be billed with the appropriate code for these services. 99232 is the next most common rejection, subsequent hospital visit. Again, claims should be submitted to Railroad, or the patient insured HIC number and name do not match, which is the Medicare beneficiary identifier. G0522 is also one of those management for new patient with dementia, but this is low complexity for use in that Centers for Medicare and Medicaid Innovation model that I talked about. Patient not enrolled should not be billed, or should be billed with the appropriate code for these services. The next two most common reasons for rejections of geriatric medicine claims are lab services. 80053 is the comprehensive metabolic panel, 14 different substances in the blood. 85025 is that complete blood count, or CBC, with automated differential. For both of these, the only reason they were rejected by WPS was the rendering physician number was invalid or missing. So what do you do to fix it? You fix it, resubmit it in order to receive payment. So you'll need to look at your claim processing or claim form instructions. Make sure you're putting this in the right place on the claim. Make sure it's a valid number. If it's missing altogether, add it, and so on and so forth. Let's talk denials now. You know the difference between rejections and denials because we talked about these. The number one reason that geriatric medicine claims were denied by WPS is that these services were denied because the patient is in a hospice. Okay, so it shouldn't be billed then to WPS. Patient in a hospice, this home health hospice coverage. Collection of fee for service during periods of managed care. Well, that, folks, is a really good example of one of those cryptic messages that I talked about earlier. 307 claim lines denied for this. What this means is that particular beneficiary has elected a Medicare Advantage plan. They have Medicare Part C. So the claim should not be submitted to Medicare Part B. WPS is the MAC. We are Part A, Part B. We are not Part C. So in this case, we're denying the service because the patient has Part C. Look at the next one and that last one. Duplicate charge paid on such and such a day on claim would have the ICN connected there. 175 claim denials because it was duplicate. It's already paid on another date on another claim. The last bullet here shows that this is a duplicate of a claim that's now being processed. So 2 like claims in the system same time being processed. So 145 denials there. The reason why I'm talking about both of these together is there is a lot of different reasons why a claim can deny as a duplicate. Could be, you know, a claim now being processed, maybe one that was already processed, and so on and so forth. What you need to do here is determine whether or not it really is you need to check the status of that service. Was it already billed and denied? Is that why it was resubmitted to Medicare? Was it simply a duplicate because you use a billing service that just automatically on a cycle submits a claim if you haven't done due diligence to know that the claim was denied previously or paid previously? There could be a number of reasons, but what I'm trying to point out here is that this continues to be problematic. I have been in Medicare for many, many years. I have been educating about duplicates for many, many years, and still we have so many duplicate claims denied every single day. If you were to put a dollar amount on every one of those duplicate claims, you can only imagine how that would add up, because not only is it costly for a provider to prepare and submit that claim only to be denied as a duplicate, think of the monies it costs the Medicare program to process that claim. Together, that's a lot of money that's being paid, that being used just simply to deny claims, and it is considered abusive. So if you're using a billing service or within your organization you bill every 30 days and you haven't checked the status of that claim, it is considered abusive, and you need to stop doing that. Okay, so we do have an article or resource on our website that speaks to duplicates, and I'll include that, or I'll point it out to you when I go through those resources. Another common denial reason, not just for your specialty, but for others as well, and a lot of these I'm finding when I analyze data for other specialties are the same, is this one. The time limit for filing your claim is expired. This, folks, is one of those exceptions where there is no appeal right. Okay, you will not find that information on your remittance advice about appeal rights because there is no appeal rights. I do want to point out to you on our website a resource, and it's timely filing. I'm going to just key the word timely. You'll notice that I've looked for it before. Choose timely filing, and this is included in those resources at the end of the presentation materials. I've listed tons of them. This talks about timely filing of claims. What I want to talk about today, we know that you have 1 year from the date of service to file a claim. What I want to talk about today is this reason that we can't reopen and pay a claim that wasn't filed timely. A claim not filed within time limits due to a third-party error. It says here, providers often ask us to reopen their claims for timely filing when another insurance recouped their previous payment, which is what caused the delay in the claim coming into Medicare. CMS, in their internet-only manual, publication 100-04, we've got a link embedded in this resource, states that this is not or does not constitute good cause for purposes of reopening an initial determination. So when you ask us to reopen a claim because somebody already paid on it and now they're coming back and taking their money back, even many years later, we can't make payment. We can't reopen and make payment because of this right here. So that might be something you want to come back to later if that's been an issue for you within your organization. Now, there are some situations where there is a good reason for us to extend the late filing limit or to reopen the claim. However, you need to file a waiver, and this resource tells you how to do that. You'll notice this one's for Indiana, Michigan, so that means if you're in J5, you would want to look at the J5 page so that you have Kansas, Missouri, Nebraska, and Iowa information. That tells you how you can submit a letter and evidence to our claims manager and request that we reopen your claim that was denied for timely filing. All right, let's see. More denials. Procedure must be billed with the primary service. That is due to an add-on code edit, which is part of the National Correct Coding Initiative. So you need to make certain that the procedure that you're billing is billed with a primary service. You need the primary service billed in order for us to make payment on the add-on code. I'll show you where you can find those resources. Here's one, expenses incurred after coverage terminated. This is an eligibility denial. So you need to make certain you're checking eligibility there to see when coverage was terminated. Here's another duplicate, folks, 59 more denials. I apologize. Deny hospital service when provided by a non-attending physician, 56. I'll show you where you find resources and talk about that a little bit more. And not covered when performed, referred, or ordered by this provider. This means that that particular provider identified on the claim is not one that can order and refer. CMS does publish a list of providers. There's a link out on their website to get to it, and I've included it in your resources. That is a list of all providers who can order or refer services for Medicare. It includes their National Provider Identifier, or their NPI. So that would be a great resource for you in order to avoid denials for referred or not covered when referred or ordered by this provider. And then, of course, when it's not covered when performed by a provider, what you need to consider there would be state scope of practice. Those are the rules that WPS follows. Basically, if your state says you can do it, unless there's a particular law or reference or rule on CMS's website that says your specialty can't do it, you wouldn't be able to do it if the state that you're performing services in doesn't certify or license you to do it. Let's take a look at the codes. The most common rejected, or I caught myself, denied service is the 99309. The 99309 is that subsequent nursing facility care, high complexity. These services are denied because the patient is in a hospice, the time limit for filing your claim is expired, and the patient has Part C. Let's talk about hospice for a little bit, where you can find information about hospice coverage and when Medicare Part B will or will not pay for it. If you look on our website, you will find a resource that's called Billing Services During a Hospice Election. This is included in your resources. This tells you that Medicare restricts payment of those professional services if that patient has chosen the hospice benefit, home health and hospice. Talks about the election, services that Medicare will allow during that hospice election. Basically, all the services related to the terminal illness are not covered by Part B while the patient has elected hospice coverage. So this talks about it, and also talks about hospice when the patient has a Medicare Advantage plan. So if this applies to you, if your claims are being denied because the patient's enrolled in hospice, this would be the resource that you'd want to come to and find that helpful information and instruction in order to avoid those. Most of our resources, if not all of them, also includes resources at the end of the article. You'll find links embedded to take you right to the citation that says we are not allowed to pay for this service. Or where does it say? A lot of providers ask us, where does it say that? You'll find those resources listed right within our articles or resources. G2211, this is a relatively new code. This is an add-on code introduced by CMS in 2024. This recognizes the complexity of the longitudinal patient relationships during office and outpatient evaluation and management services. So what's happening here based on the data that I analyzed is this procedure is being billed, but it's not being billed with the primary evaluation and management service. So it's being denied. You can see another common reason for denial, service not payable with other services rendered on the same date of service. It has to be billed with an E&M. How do you find out information about billing this with an E&M and that Medicare is only going to cover it with an E&M? You can look to those. There's a number of there's resources available on our website, or articles, if you will, and there's also some really great what do I want to say here? YouTube videos out on our YouTube channel, and I've included all of that as resources in your packet. Expenses incurred after coverage terminated. Okay, so patient no longer has coverage, and the service is being billed. It's going to be denied by Medicare if that's the case. If the patient wasn't eligible on that day, we can't pay for it. 99308, that's subsequent nursing facility care for a patient with moderate complexity. Patient had Part C. Oh, no, let me go back. 308, I'm on the top one here. The services are denied patients in a hospice. Patient had Part C. The time limit for filing your claim is expired. So you could see these are kind of repeating themselves over and over. It's the same reasons but different services that WPS is denying for specialty 38 or geriatric medicine claims. So, you know, take this information back to your organizations, share it within, check to see if these are the reasons your claims are denying so that you can avoid those denials in the future. Get payment more quickly when you're entitled to that payment. Patient has Part C, more hospice, expenses incurred after coverage terminated. 99214, that is an evaluation and management service or office visit, office outpatient visit. Why are we, WPS, denying it? Because it's a duplicate. You know, if you submit it the first time and we deny it for whatever reason, you need to change something. You can't just resubmit it. You need to request an appeal and provide the documentation that supports that we can pay for that service. Patient has managed care, which is Part C, is the other reason we're denying it. G0439, that is the subsequent annual wellness visit. Why are we denying that? Because the benefit maximum for the time period or occurrence has been reached. That is a form of utilization parameter. We can only pay it so often, so it's exceeded the maximum for the time period. This one's a little tricky because sometimes you don't know when another provider has performed that AWV, that annual wellness visit or subsequent annual wellness visit. You know, ask your patient, check the SecureNet Access portal to see when that last service was rendered. Make certain that you're waiting the correct amount of time before you bill it each year, so on and so forth. Just ways you can avoid those, and expenses incurred prior to coverage. So here I wanted to include, I mentioned to you before, trending that we've done. For time limit is expired, no appeal right, I want to show you the kind of data that we can quickly pull using that that tool, that database. Current 3 months, 154 claim lines denied because the time claims denied because the time filing has passed. The prior 3 month, we only had 57 denials. There's a 97 claim difference. That's a 170% increase since the last 3 month period. So why do we look at this? We look at this to determine what education we need to provide. Things like what I'm doing today. Why did I talk about those common rejections and denials? We want to fix them, avoid them in the future. For timely filing, what we have done is that one of my colleagues has recently held a webinar about timely filing. We recorded the webinar. It is now a YouTube video so that providers can have this education and avoid this. You know, we do look at trending. This is just one good example. The next few slides, and I'm not going to deep dive into them, are how to fix these things we've talked about, but I've really kind of talked about that already. So I want to point out to you that your modifier issue fixes that I've already mentioned are here on this slide. Make sure your modifier is valid for the data service. CMS adds new modifiers or quits using modifiers. Make sure they're valid on the day. This is some of those eligibility fixes. Remember that patient name and MBI have to match. Make sure you're submitting claims to the correct payer. Does the patient have Railroad Board Medicare? Or does that claim you need to go to the United Mine Workers of America to their health and retirement funds people? Provider number fixes. This is basically keying errors, checking your provider enrollment records to make certain you're entitled to payment on a given data service. Make sure your rendering billing provider is, or your rendering providers associated with the billing provider. Sometimes they're two different providers on the claim. And ordering provider information is entered correctly. And I'll point that resource out to you in a minute. This is all about those duplicate denials. Don't auto resubmit every 30 days. Make sure that your billing are using the modifier or modifiers appropriately, because sometimes use of a modifier will avoid a duplicate denial. So look for those. I'm thinking, oh gosh, 76 and 77 modifiers. Take a look at those. Those might be valid for you if you're receiving these denials. And here, folks, are all of those resources and tools. I give you on this slide links to claim form, Medicare claim form instructions. I do want to show you really quick this crosswalk tool. We have instructions for paper claims. We have instructions also for claims that are electronic. And we have this crosswalk that our EDI staff has made. And this is a crosswalk that tells you along the first column here, and I can't highlight it, under item 1, if it's item 1 on the paper claim form, it's the type of health insurance. It's a claim filing indicator code. It must be on the claim for Medicare Part B claims. The status code is an R, which means that that data element, item 1 on a claim form, is needed in order to process a claim. When you see an S in this status column that on the crosswalk, it means it's situational. It must be completed if other conditions exist. So you can look at this for any item or any number on a claim form, item 8, for example, item 11, for example. It tells you what is required or situational on a paper claim form, but it also tells you the crosswalk to where it needs to go on the electronic claim. It also tells you the requirements for the version 5010. What is it that you need to place there in those places on the electronic claim and in what format? So this is a great tool a lot of providers don't know about. I like to share it because I think it's awesome. That is the crosswalk. We have those articles. We have the IVR, which is the Interactive Voice Response System, which is a way you can look for claim status and details. This is a self-service tool. We have instructions on using it. Similarly, we have instructions for the portal user manual. I pointed those out. This one you can use to check status, claim details, claim actions, and check eligibility. So this is a great tool for claim denials that you may be receiving when you receive notice on that remit. We have both for rejected claims and also or denials listed by reason and remark codes, resources on our website that say, if your remit notice has this reason code on it, this is what you need to do to fix it, or this is what you need to do to avoid the denial. We do list those reason and remark codes for denials in different categories like duplicate, bundling, so on and so forth, as you can see here. But I've linked to all of these, our website. This is that article about how to request a clerical error reopening. You can use our SNAP in order to do this as a self-service. You can find instructions for that in the user manual. But this article on our website or resource, how to request a clerical error reopening, does a really nice job explaining the process and listing for you what you can use the clerical error reopening process for and when you can't use the clerical error reopening process. So really great resource. Modifiers webpage showed you that, showed you timely filing of claims. I showed you the billing services during a hospice election. Live events webpage is where you can find on our website a list of upcoming webinars. Encore Presentations is where you'll find those recordings for 60 to 90 days. Place of service codes for professional claims. I think one of the rejections that we talked about today, or denials it could have been, is that this place of service doesn't go with this procedure code. Maybe you need to visit that list of place of service codes to make certain that you're reporting them correctly. Here I've included a link to our YouTube channel, including one that I think you'll find interesting based on the data I looked at. We have one about Medicare Advantage plans, those Part C plans, so we want to avoid some of those claims that are being denied because they're coming to us. Here is some resources about checking eligibility. CMS has on their website an interactive map where you can click on any state and it says, here's where you need to send a claim if the patient has railroad, for example. So that's kind of a nice contractor directory. I talked to you about ordering and referring. The providers that are eligible to refer and order Medicare services, and they're listed in a searchable file and have the NPI available so that you can report correctly and accurately on your claims. Those edits that we have in place that require you to use a primary procedure code before you can report an add-on code, those are correct coding initiative edits. They're called the add-on code edits. The code that I provided the example of in this presentation is G2211. You need that primary code before you can bill the add-on code. Here is information about that guide model, that comprehensive primary care model for patients with dementia. This was a big hit for your specialty because your patients weren't eligible because they weren't enrolled. Here is where you can find the information if you want to submit those services to Medicare. So a lot of great resources available for you. This would normally be the time we answer questions and answers, but I had a lot of information, as I mentioned to you earlier. We will not have time for those questions you may have placed into the chat. Remember, I can't answer claim-specific questions, but anything related to what I talked about today, I am more than happy to answer, and I will get those answers to those questions that were placed into chat out to you following this event. CMS, or actually WPS, wants us to make you aware of a process change. This is a change that is pertinent to customer service. This talks about it. We are beginning August 4th, only going to allow one NPI and PTAN combination per inquiry or per call into our call center. This explains why. You may have already read about these changes, but because we published this in our news and on our website. I want to mention to you that we are very committed to making changes to improve our customers' experience. Based on your survey comments, we have made changes to YouTube to allow chapters so you can easily jump around within a recording. We've also started using training indicators in our advertisements so you know when specific webinar content pertains to what you do or what your position is at your organization. So keep those suggestions coming, and the best way for you to do that is to make certain that you're completing that brief survey we ask you to complete following each event. I want to talk about the Certificate of Achievement. Some of you may be seeking continuing education units. The way we do this is we give you a Certificate of Achievement, and it is not an attachment. It is simply a follow-up thank you email. It actually comes from our WebEx, or from WebEx. That's the platform we use for our webinars. The language is embedded in that email you read. There's no attachment. It's going to certify that you successfully completed this training. It's going to give you the name of this event, the contact hours, and the date. That will look just like what you see here in this red box. If you joined only by phone, you are not going to receive the automated thank you mail because they don't have your email address to send it to. In that case, you need to send us an email and send it to the education mailbox. The address is on the next slide. We've talked about it before. Elaine's placed it into the chat, but give us the completion date, today's date, the name of the webinar, and give us your telephone number. Then we can make certain that we verify your participation, and we will send you a manually created Certificate of Achievement, and that will be an attachment. Finally, or not finally, almost there, and I apologize, I've gone over a little bit here. If you think of any presentation related questions and you didn't put them into the chat, but if you think of them for the next 7 days until noon a week from today, if you send an email to the education mailbox shown here on this slide, include today's topic in the subject line, I will include an answer to your question when I send out those questions and answers. Now, if I don't get any questions, I won't be sending them out. And some of them might be those that would pertain only to the learner. So I might just send a response out to a single learner, but I might also create that list of questions and answers and send it out. So do feel free to send those presentation, not claim specific questions to me for a week following today's event. And finally, we do want you to take a few minutes to complete a survey. Tell us what you liked, what we could do better, suggest topics for the future. Remember, this is how we make changes. If providers ask us to add chapters to our videos out on our YouTube page, we take that information back to those that need to know, and we ask, can we do this? We want to make certain we're giving you the education you want and you need. This is so important to us. We've embedded the link in that follow-up email that you're going to receive. And when you exit today's webinar, there's going to be a pop-up. It's going to look like what you see at the bottom middle of the screen. It's got the yellow triangle at the top and blue button. It is not malicious. It is fine if you've not already done the survey to click on continue and then complete that survey. Your feedback is invaluable. It ensures our education is timely and effective. At this time, on behalf of myself and Aline and the entire Provider Outreach and Education team, I want to thank you for participating today. We look forward to those survey comments and we hope to have you join us for future events. You may now disconnect. Thank you all for coming today. Bye.